And so, good morning, everybody. As I was saying earlier, this is the Asthma Advisory Panel on asthma and climate change. We're very fortunate today to be joined for a purpose of presentation and discussion by our environmental health colleagues, quite a number of them, and then also a little later this morning by Dr. David Kaminsky, Professor of Medicine and Pulmonary and Critical Care Medicine at UVM Medical Center. So we have I believe, a great program of discussion and presentation. And before we start, though, I would like to just give you a chance to if you make sure that you mute yourselves just in between, that would be great. And then please feel free to write down into the chat your name and organization, and maybe any interest you have specifically in climate change. We'll be following up with that topic again a little later with our evaluator, Emily Grosvenor, who will help us kind of discuss and focus on this a little bit more as a group. Emily, just want to quick touch base with you real quick that's the case. You will be engaging around that, and we'll hold off on introductions until then.
Yes, I can go ahead and do that.
Okay, great. Thank you. All right, so let's go ahead and start. I'd like to introduce Lauren Prenzing to lead us off to discuss heat-related adverse events and take the reins. Go ahead, Lauren, if you're ready.
Karen.
There you are.
Yeah, hi. I'm here. I will go ahead and get my slides shared. All right. So thank you so much for the opportunity to present this morning. As Karen mentioned, my name is Lauren Prenzing, and I'm an epidemiologist in the Division of Environmental Health at the Health Department. And I'm just going to give a brief overview of some of the health impacts of heat we've observed this past summer. So I will start out by noting that all of this data is in the so far category. We do consider the warm season in Vermont to be May through September, so we certainly could get a few more warm days in the coming weeks, but the data I'll be presenting this morning is through this past Monday, August 26th. So up until the end of August, we saw 56 days this summer that were 85 degrees or hotter. 14 of those were 90 degrees or hotter. And that kind of mid-80s threshold is important because that's where we really start to see health impacts of heat increase significantly in Vermont. All of you will probably remember the major heat event we had in late June, where it was quite oppressively hot and humid for several days in a row. And then throughout the month of July, we had a lot of just kind of above average hot and humid weather. I'll also note that there was quite a bit of flood cleanup activity happening in July. And as we'll see in some later slides, conducting physical labor outdoors is certainly a risk factor for heat-related illness. So all of that to say that through mid-July, we saw about a 60% increase in number of heat-related emergency department visits compared to kind of what we would expect at that point in the summer when we look at data from the last 6 years or so. So the first kind of half to 2/3 of the summer, we were really seeing significant heat-related illness in the state. So I'll just briefly touch on the 3 data sources that I used for this kind of near real-time analysis. I used Essence, which is our syndromic surveillance database, which includes data from all 14 emergency departments in the state, as well as a portion of the urgent care facilities. We looked at Siren, which is our emergency medical services or ambulance data, and then the National Weather Service. I got the maximum temperature data from them. So just a note that because this is near real-time data, all of these numbers may change in the coming weeks and months. So I'll start out with just this kind of overview or essence data at a glance. So this graph may be familiar to some of you. It is on our website and updates every Monday morning, May through September. So just kind of show that these blue bars are the percentage of ED visits each week that were heat related for the current season. The purple line is the historic average percentage of heat related illness for that week of the summer. And then the yellow line is the historic maximum. So we can see this heat wave at the end of June and then warm weather around the 4th of July did result in 2 weeks where we set a new record for the percentage of heat-related ED visits for that week of the summer. And then we had a couple of other weeks that were just kind of above average utilization for that week of the year. And I'll just note that this pattern is actually pretty similar to what we saw last summer as well, in terms of quite a bit of heat-related illness in late June and throughout July. And then you can see here just kind of this sudden change in August where we've actually had relatively cool weather and pretty minimal heat-related health impacts in the last couple of weeks. So then when we dig a little bit deeper into some demographic information, we'll see that this past summer and kind of pretty consistently across the years in Vermont, more males than females seek care for heat-related illness. And then in terms of age group, we kind of have these two groups that pop out, younger adults, so ages 19 to 40, and then older adults, ages 61 to 80. And these patterns look pretty similar across both the emergency department and the EMS data. We've kind of always thought about this older group as being higher risk, but the last 2 years in the Essence data, we've seen this 19 to 40 age group actually have the highest proportion of visits. So I think we'll kind of see some of the reasons why in the subsequent slides, but definitely a group to perhaps be messaging towards in the coming years. One of the really helpful features of the EMS data is that we're able to see the location that the ambulance was called to. So we can see here that for about 34% of the heat-related EMS calls this past summer, they were called to a home or a private residence. So that could either be the person who became ill's home or just a home that they were spending time at. About 18% they were called to a road or a parking lot, and that's just what it sounds like. They found someone kind of on the sidewalk or not feeling well in their car in a parking lot. 12% or 13% to a recreation area, and about 7% to a sports field. And then I lumped everything else into this other category, which included a variety of things like bodies of water, school, place of work. And then we're also able to look, there's a really rich narrative field that accompanies each of these calls. And so we were able to kind of glean some information by reviewing those narratives to kind of see what were people doing prior to experiencing heat-related illness. And some things that popped out there included participating in team sports, outdoor recreation activities, which includes hiking, biking, running, and then work, which could either be someone's paid occupation or doing things like yard work, gardening, things like that around the house. And then we can do kind of a similar analysis with the Essence data, with one twist being that we're also able to look for co-occurring health conditions in Essence, which is really useful since we know that people with pre-existing chronic conditions may be at higher risk for heat-related illness, and this lets us kind of really dig into which types of pre-existing conditions. So we saw a lot of co-occurring mental health or substance use, circulatory system conditions, respiratory, including asthma and COPD, as well as diabetes. And then again, we're able to do kind of that risk factor analysis here. And common themes again included occupation or yard work, as well as outdoor recreation. And then I just wanted to note that while these near real-time data sources are great, they are not perfect. So just wanted to note that we are missing some things here. The risk factor identification piece relies on keyword searches. So that means that the person needs to say something like, I was playing softball or I was working in my garden before experiencing heat-related illness, and that then gets documented in either the triage note or the narrative field in Siren. And the real wrinkle here is that for the Essence data, not all emergency departments send detailed triage notes to Essence. So for that particular data source, we're really just looking at kind of a piece of the pie for that risk factor identification piece. Also wanted to note housing status. We know that folks who are unhoused are at increased risk for a variety of environmental exposures. And we are able to identify if someone is unhoused in both of these data sources if that gets documented. And I do think we're kind of trending towards better documentation of housing status, but just wanted to note that that's likely still an undercount. Unfortunately, Amy and Jared in a little bit will be able to talk in quite a bit more detail about the health impacts of heat on the unhoused population. And also just wanted to note farm workers, particularly migrant farm workers, we're likely missing a good chunk of that data as well. And then lastly, to end on a what can you do note, I'm just going to breeze through some of our heat-related illness prevention strategies, and then I'll drop a link to our website in the chat. So if you want to look into any of this in more detail, you can. But in terms of preventing heat-related illness, we want to think about always checking cars for children, people with disabilities, or pets after you park, not just, closing the door and walking away. Staying cool by finding shade, air conditioning, or other cool places, making sure that we're drinking more water than usual and drinking water before we start to get thirsty, taking it easy when we're working outdoors, doing yard work or exercising outdoors, and as much as possible, trying to do these types of activities in the cooler parts of the day. And then lastly, checking on family, friends, and neighbors, especially older adults or those with chronic health conditions. And that's all I have. I'm happy to take any quick questions now or can answer some later. Thank you.
Yeah, Dr. Rappaport.
Sorry, I'm on mute. Hi, I'm Lauren. In terms of other things that are missing, I wonder if are you able to capture any medication data from the ERs? And the thought was triggered by the mental health conditions because a lot of the antipsychotics can cause problems with heat.
Yeah, that's a great question. I have actually not looked in that data source to see whether medication information gets captured there. I'm guessing if it does, it's not super detailed, but that is certainly something I could look into in the future.
Sure. It would just be interesting to see how much of a factor that was for some of these.
Yeah.
Any last question? Jared.
Hi, Lauren, I was just wondering if there was anything useful you could comment on about detecting asthma exacerbation related to hot weather. I know that's something that we've kind of poked at a little bit and has proven challenging. And yeah, just wondering if there's anything useful to share on that.
Yeah, I guess I don't have a great answer to that question. So in essence, all I can see is that asthma showed up as a co-diagnosis for that ED visit. There's not a lot of detail about whether the person just has asthma and that was documented or if they were experiencing asthma exacerbation in addition to the heat-related illness. But there's a couple of other data sources at the health department that I'm thinking on whether there's the ability to do something like that, but don't have a great answer currently.
Okay, thanks. Didn't mean to put you on the spot. Yeah, I was just kind of thinking about how that there's pretty good evidence that heat-related health impacts are really underreported, maybe by a factor of 10, according to some sources, because there's so many other conditions that are sort of tied in with heat exacerbation, and so it might not end up getting coded as like a heat illness per se. But I suspect in our data, if we had perfect information, we'd see some sort of trending of like asthma exacerbation sort of correlating with the increased impacts on the specific heat illnesses that Lauren was able to document. So I just wanted to address that a little bit, that there's a lot of data analysis challenges with kind of detecting that, but that's sort of part of why we're bringing this here and thinking about this in conjunction with asthma, just knowing that there's a lot of correlation between heat impacts and asthma exacerbation.
Yeah. Rhonda, did you have a question? No? Okay. I thought you go ahead.
Well, just a quick mention is that due to infestation of several tree species, not just in Vermont, but coming to Vermont, and there's going to be quite a loss of tree cover in some areas of our state due to both preventive and also trees already infected by pests, in part due to climate change. And so just noting, Lauren, that one of the strategies for preventing heat illness is one that is, potentially will become harder to access as we move forward through this challenge.
And then I just had one item, Lauren, is the question about humidity on those very hot days and whether we see a difference there in terms of those, especially as it relates to those with asthma and ED visits or what have you. Was that part, do you have those measures in there as well?
I did not look at that here, but Lauren Rescue and I have been just starting to think about kind of a more in-depth environmental exposure and asthma exacerbation analysis, and as our humidity is one of the things that we were considering there. So potentially more to come on that topic, but not included here.
Excellent. Okay, great. Thank you. Well, thank you so much for your presentation. It's very interesting and gives us a lot to ponder and think about, and maybe, bring back around, then what? What next? What do we do? And so thank you. Shall we move on? And I'm glad to introduce then Amy Redmond and Jared Ulmer to take us to a few projects and topics of interest underway. And so there you are, Amy. Good morning.
Good morning. I'll start with a quick intro and then hand off to Amy
okay.
to introduce herself. So Jared Ulmer, I manage the Climate and Health program at the Department of Health in the Environmental Health Division. So yeah, Lauren's presentation teed up really nicely what Amy and I are going to talk about with her point of not everything is documented in medical records. I also mentioned the underreporting of heat illnesses. And so I think based on some of the analyses we've done over the years with the data sources Lauren described, we were feeling like we didn't really understand the heat impacts on unhoused Vermonters in a very substantive way. I mean, we had assumptions, we had evidence from other places, but we just didn't see a whole lot of documentation of heat illnesses connected with clearly somebody being unhoused in the quantitative data. And so we wanted to dive into that more because a lot of our strategies are really driven by the evidence of who's most disproportionately affected and may need support. And we didn't feel like we had the evidence for the unhoused population. And so as a result, we weren't really doing much in response. And so that didn't feel right. So Amy and I got together a couple of years ago with an opportunity to engage Middlebury College and some students on exploring a more qualitative kind of interview-based approach to learning more about heat impacts on unhoused Vermonters. So I'm going to hand off to Amy to talk a little bit more about the project and what we learned, and then we'll circle back around to some of what we're doing now as a result. And I'd love to also solicit a little bit of feedback about how we could kind of like tap into some of the new relationships we're developing to support not just heat safety, but respiratory health and other conditions. So I'll stop there and hand off to Amy.
Thank you, Jared. Good morning, everyone. It's great to be here, and we're grateful for the time to share this project with you. So I'm Amy Redmond. I use she, her pronouns. I'm the Environmental Justice and Health Equity Advisor at the Department of Health. I work in environmental health and get to work with the climate and health program. So yes, as Jared said, I'm going to give like a 5 or 6 minute overview of the drafted heat and houselessness storytelling project. So I'm going to share my screen with all of you. And Jared, you'll give me a heads up if there's any kind of like audio or visual accessibility issues, hopefully. Okay. Is that good, Jared? I can see you. Is that okay?
Yeah.
Great. Okay. So, yes, this is the Heat and Houselessness Storytelling Project. It's a draft. It's in a Power BI report. Eventually, it will live in on the Environmental Justice and Health Equity webpage and have some more information and context and framing. But this is the current draft. And so I want to show you just a few pieces of the project. I want to show you the main pieces of the project and share some of the quotes with you from the unhoused folks that were interviewed. I'm going to share a quote from the main storytelling project, which is a series of quotes with audio and then accompanying narrative. Also share a quote with you from the full set of quotes. So this project included 19 interviews with unhoused folks and also with 7 service providers. So there are a lot of, this is just a full set of quotes without narratives. I'll share the key, some of the key takeaways, and then I'll also just show you briefly some of the things that we've listed to get involved. So firstly, I want to share this quote with you. This does have health information, so it's distorted, just to give you a heads up. So I'll share this and then the narrative that accompanies it.
Yeah, I've had heat exhaustion or heat stroke, whatever you want to call it, several times. Yeah. The first thing you notice is you stop sweating and you get a headache. The headache gets very severe and you start vomiting. You'll feel cold, goosebumps. When you're in that stage, you need to get help.
Were you able to access help in those?
No, immediately. Immediate help in that situation is pretty crucial. If you're a strong-willed person, you can walk in hours to get to where you need to go.
Were you mostly alone for some of those?
Yes, always.
Yeah.
So the narrative that accompanies this quote says, "Heat poses a heat threat to us all. Without a reliable place to cool off or close support from others, heat can quickly turn into an emergency. Several folks interviewed mentioned they experienced heat exhaustion, heat stroke, or dehydration. Others mentioned how underlying health conditions such as asthma and side effects from medications made them more sensitive to heat exposure." So the main storytelling project goes on in this rhythm of quote, audio, and narrative. But I want to take us back to share another quote from an unhoused Vermonter from the full set of quotes that explicitly mentions asthma. So I'll share another quote with you.
Now I go forward to the heat. Try that asthma, so that like flares up big time. Uncomfortable, so.
Have you experienced any heat-related health issues?
Heat stroke, dehydration. If I'm outside for too long, I'll get dizzy. I get like, even if I'm not even sunburned, so my body doesn't receive sun well. I break out like hives from the sun, like these bumps. Well, I know spring's coming, and I know summer's gonna be coming very shortly, and the thought of sweating to death every day is not. But hopefully.
Let's stop that there. Back. Okay, I want to share just a few other, I'm going to share the key takeaways with you. Okay. So, the key takeaways include that qualitative data gathered during this project suggests that people who are unhoused commonly suffer health impacts due to hot weather and often lack access to needed safety resources. The data from this project was analyzed and coded for themes, and one of the most salient themes found was that of stigma. So the second key finding here is stigma presents a significant barrier to unhoused Vermonters accessing necessary resources. Creating a more welcoming environment for Vermonters experiencing houselessness could have as much impact as providing new resources. We also have systemic changes listed here. So we know that systemic changes are needed to improve heat safety for unhoused Vermonters. For example, long-term solutions to increase access to affordable housing, public community spaces, and healthcare. And at the same time that long-term systemic changes are needed, there's also immediate things that the data that we found that was found in the data. So for example, providing temporary shelter, storage, and survival gear can help meet immediate needs for the short term. And included in this is a 2-page summary of this project. So it has some context on climate change and heat impacts, and then also quotes and audio, and then a list of the immediate needs that were mentioned in the data from this project. And then really briefly, the project also includes things that folks can do. There's the cooling site maps that are listed here. So spreading information about the cooling site maps and how to stay safe in the heat, working, volunteering at a shelter, also learning about the root causes of homelessness. And we have taken the data from this project and included sharing resources based on the things that were mentioned that would help, particularly in the short term, ranging from hydration resources to sun and insect protection. So I want to stop there, Jared, and invite you in before I stop sharing this to see if there's anything that you want to mention specifically about this before I stop sharing the screen. Is there anything?
I don't think so. Whenever you're ready, I would just transition into some of the sort of work in progress things that we're doing. Yeah.
Great. I'm going to stop sharing that piece then, and I'll hand it back to you if that feels good.
Great. Yeah. Thank you, Amy. So yeah, I think depending on your I don't know, life perspective experience, you might have heard some of this and been like, okay, yeah, a lot of that was obvious. I think for us, there were some things that were kind of expected and obvious, but others, like how much stigma kept coming up in the conversations, like it was something that I was maybe aware of, but maybe not how pervasive and kind of how destructive it was in terms of acting as a barrier to accessing resources. So I think at a minimum, for us, since we were kind of lacking that quantitative data to say, hey, this is a group that's being affected, here's some specific strategies that may be needed. This qualitative data really sort of plugged that gap for us and really making it so obvious that there are pretty wide-ranging impacts in this population, not just heat. A lot of other topics, health related issues came up in these conversations, and that the unhoused folks and the service providers were directly suggesting like what things are needed, both long term and short term. So that's been really helpful for us to just kind of initiate some next steps actions, particularly in partnership with the folks at the Department for Children and Families and their Office of Economic Opportunity that oversee some of the grants and provide other supports to shelter directors, to service providers, to unhoused Vermonters directly. That wasn't really a collaboration that we had established before this project, and so this project really helped to kind of kick that off. And we've learned, so much about the great things that they're already doing and how we can kind of tap into some of the existing, structures and funding opportunities to support heat safety and other sort of summer safety concerns. One thing that we learned about was the housing opportunities program grant that is administered by the Department for Children and Families, and that helps provide supplies and resources to shelters and to service providers. And so we had a conversation about them of like, well, could that funding support sun hats, bottled water, insect repellent, KN95 masks when wildfire smoke is bad, and it's basically like
all your food out.
Yes, like yeah, we can support all of those things. And it's kind of up to the shelters or the service providers themselves to request the items that they need. But one of the things that we've been doing with our partners has been to just raise awareness that like these are needs, and if you don't already have supplies to support these needs, that could be purchased through this grant. We've been able to do some outreach with the shelter directors about that directly, and then it's coming from the Department for Children and Families as well. We learned about street outreach teams, which I think were an informal kind of grassroots concept a few years ago that's getting a little more formalized and supported. These are local groups of folks. I know in Burlington, the Howard Center has a street outreach team that literally goes out into the community to encampments, to places where unhoused folks might congregate during the daytime, and just checks in. How are things going? Bring some basic supplies with them to provide support. And so that's another kind of conduit that we can kind of work through, help support them with resources and awareness about some of these topics, to be able to bring that out into the community. I'll stop there because I want to have a few minutes that we can hear from you all. But I wanted to mention some of those because in all these conversations, we don't just talk about heat. Like we talk about summer safety, all those different topics that I mentioned. Eastern equine encephalitis is like a big thing right now that there's a lot of concern about, and so like we're helping, or we're using those channels to try to help address that issue as well for this population. I wanted to just ask folks here if there are other suggestions or strategies or like key resources that you think could be effective at addressing asthma attacks or asthma exacerbation through those types of channels, or just any other questions or comments about the project at large. But I just kind of wanted to invite that like that pathway of collaboration is open for us right now, and we want to tap into it as broadly and effectively as possible.
Any questions from the group or comments? I just, in kind of response to your question, Jared, I think first I thank you both for your presentations, but I think in a way hearing these quotes and realizing you could hear in the quotes a kind of anticipatory dread of the upcoming season, and then the fact that several individuals had experienced some sort of significant impact of heat, and had to kind of, what did he say, be strong-willed about it to get through. It is very impactful in helping raise awareness and ignite greater empathy for this subgroup and awareness that that there are quite a lot of individuals who know it's a risk. They know it better than maybe some of us in public health because they've had to go through it. So I think that's one answer to the question, Jared, is sharing those a little bit more and awakening our awareness and realization and empathy to the issue. And then, I think there were a couple of things there that it was interesting to hear as it related to those also who happen to have asthma and the effects on their ability to control asthma. And it makes me, I jot down the issue, your examples there of street outreach teams as a possible, at least just to touch base in terms of resources. I'm not sure what's possible there in terms of, bridges that they have with clinical teams or what have you, but that's kind of what I was pondering. Anybody else? Last question. Rhonda?
Yeah, I'm glad you brought that up, Karen, because I was just reading about how having asthma can make you more susceptible to heat stroke, and that it's important. And I'm thinking of those who are houseless and don't have access to cooling interventions, that maybe with those street outreach teams, we could have a conversation and provide, if they want, information on the importance of having your medication handy, your nearest. I love that map of the cooling stations and what's the cooling station nearest where your encampment is. So Jared and Amy, I love this. Thank you for covering this important topic. And if you think there's a chance or opportunity for the asthma program to meet with any of the outreach teams, we'd be happy to discuss and meet with them. Thanks.
Thank you, Rhonda. Yeah, I think we're still trying to sort out like what that collaboration pathway looks like, and trying to kind of work through our local health offices to make sure that relationship is established between the local health office and the street outreach teams, and then we can kind of disseminate information and resources through our local health offices. That's kind of what's emerging, but I don't think there's any like clear path yet. So just to say, like, yeah, that makes tons of sense. I think there will be opportunities there to make those connections. I'm just not quite sure how to do that yet. We've been doing some of that like directly through our OEO partner, but I don't know that that's like the long-term right approach to providing that ongoing support to the street outreach team. So happy to check back in on that with you.
I know your population of focus was houseless, and the issue of stigma came up quite a bit. Oddly enough, in my mind, a parallel topic came up, which is not quite related to that population, but extreme athletes. I'm thinking of the several 2 or 3 Olympians who had to cancel their event in France in Paris because I think they were on those hot, humid days and heat, high heat days. And I saw that in Lauren's data. There were several sport fields scenarios, and then there were some water sites. And so I know that's a different population. It's not related to equity per se, but there might be a similar strategies that might bridge both populations because they're out beyond, if you will, and so how do you provide assistance and to these locations, if you will. Well, thank you so much. I really appreciate it, Amy and Jared. It's very interesting, and I think we'll be seeing more in terms of, as we go forward, these trends and explore implications on on all of us as well as certain subpopulations. So thank you. If we can now turn over yes, Amy, anything else? Oh, okay.
I was just saying thank you.
Oh, yeah, no, it's a delight to have you with us. Thank you. I'll turn over the mic and screen to David Grass and Lauren.
Great, thanks so much, Karen. My name's David Grass. I, like those other folks who you've heard from so far, work in environmental health, and it's a real pleasure to work with all these folks on a day-to-day basis. My role in the asthma advisory panel meetings for the last couple of years has been the pollen guy. So here's another opportunity to hear from the pollen guy. And Karen has been very tolerant of me coming over the last couple of years to talk about our efforts to support pollen monitoring. And that's the Environmental Public Health Tracking Program that I oversee. And for the last 4 or 5 years, we were able to support pollen monitoring with a sub-grant of about $9,000 or $10,000 that allowed us to do manual pollen monitoring. And for the last couple of years, I could foresee that we weren't going to have enough money in our budget anymore due to reductions at CDC to be able to do that. And so I was sounding the alarm to say, we won't have funds starting in 2024 to do pollen monitoring anymore. So if you want to see pollen monitoring continue, we need to figure out a new way to do that. And so I'm here with Lauren this morning to tell you, like, okay, what happened in 2024? Here we are. So what happened in 2024? A lot more than we were expecting. We thought there would not be resources to do any manual monitoring at all. This is where somebody physically goes out and puts these little glass rods that spin around and collect pollen on these greased rods, and then puts them under a microscope to count the pollen grains. But we were able to scrape up enough funds through a new collaboration through health department programs and Timberlane Asthma and Allergy Associates to be able to continue doing manual pollen monitoring on a reduced basis. So normally these pollen counts would be happening on a daily basis, like 5 or 6 times a week. This year we were able to do it 3 times a week. And so instead of costing $10,000, it ended up costing closer to $5,000. And that expense was supported by the asthma program, by the climate and health program, and by Timberlane Asthma and Allergy. So it was great to have that novel collaboration between a clinical practice and the health department to make sure that that pollen monitoring could continue this year. Before we were able to put that collaboration in place, we went ahead and purchased an automated pollen monitor with tracking funds, and with support as well that came from both the climate and health program and the asthma program. We were able to afford the software that you need in order to be able to run this automated pollen sensor. And the supplies that you need that are sort of disposable that I'll talk a bit about as I move forward. So mostly what I'm going to be talking about this morning is our experience with this new automated pollen sensor and sort of doing a pilot this summer to see how this thing works and whether it's something that we want to continue to try to pursue moving forward. And basically, I think that's a question that I need to put to you as potential users, which is this the output that we get from this automated pollen sensor something that you find valuable? And Lauren is going to provide a demo so you can see what that output looks like. So here I just provide a little bit more information about what the relative costs were. So for the manual pollen counting, that the ongoing costs of manual pollen counting are, well, this year they're around $5,000. In the past, they've been $9,000 to $10,000. For the automated pollen sensing, it's a high upfront cost for the instrument, but the ongoing costs are a little bit lower. So this is what the instrument looks like, where we installed it on the roof of the Waterbury State Office Complex. and it's a good location. There aren't any horizontal obstructions. There's good flow of air. The only company that you've got up there are a bunch of solar panels that they have on the roof. This is what the pollen sense monitor looks like on the inside. That big black thing in the middle is the microscope. The circular thing on the right is a roll of transparent tape. The small black wheel on the left is a fan that pulls the air from an inlet and blows it onto the transparent tape, and then that transparent tape slowly moves underneath the microscope, which captures images that are sent to Pollen Sense's servers, where image recognition and artificial intelligence is used to categorize the different types of particles that are captured in each image. So here's an example of what one of those images looks like. This is from back in June when you have that yellow tide of pollen, pine pollen that falls on top of your car. And that's what those pine pollen that's what pine pollen looks like up close. So you'll see in the lower left-hand corner a little rectangular box. So it's a measurement of how big that particle is. So it's about 30 microns across. A human hair is about 60 microns across. So a pollen spore is, or pollen grain, pine pollen grain is large enough that you can see it unaided with the human eye. But anything smaller than that becomes, next to impossible. So one of, the gratifications of this method is you can actually look and see, what it is that we're breathing. And sometimes when you see, biological debris or plastic particles that show up in these images, you feel like maybe it's better if I don't see what I'm breathing. Pollen Sense offers a website where you can graph the output that is aggregated from these images where the individual grains are counted. It's not particularly flexible. It's not particularly accessible. It's not accessible to the public. And so if we want the pollen data to be accessible publicly, then we have to do something to get that data from Pollen Sense to a website where users can make use of it. Here's just a listing from the Pollen Sense graph of the different types of particles that you can map out using this Pollen Sense instrument. And so you'll see that it's not just pollen, it's also dust and mold as well. So in terms of where we'd like to see that data from the automated pollen sensor go, we'd like to continue supporting the seasonal pollen tracking report that we've created using the manual pollen monitoring data in the past. We'll probably need to note that any data that we're adding to that report that comes from automated pollen sensing is using a different method, and so we'd need sort of a slightly different flavor of that report in order to show that. I don't think we'll be able to track historical trends in pollen across any sort of transition from manual pollen counting to automated pollen counting, just because the methods are so different. I think it would be misleading to just plop an automated bar on the graph right next to a manual bar on that same graph. So we want to use this data for seasonal pollen counting. We want to support continued daily pollen counting. This is a screenshot in the middle from Timberlane's website where they provide the latest pollen counts to the people who come to the website to see what those are. And we want to continue to support our partners to do that. But we also want to make the most out of this new tool, and it supports both daily pollen counting, but also hourly pollen counting and quantitative subcategory counting of the different species of plants, within those larger tree, grass, or weed categories. So I'm going to invite Lauren to take over to show you a report that she's mocked up, in order to hear from you about what is useful to the patients you see, to the people who you work with, and how can we best make use of the data that we're getting from this new tool. So with that, I'll stop sharing.
Great, thanks, David. So I will go ahead and share my screen. Okay, so I will start out by saying that this is still very much in draft form, and I have a PDF version of this report with kind of my discussion prompts included that I'm going to send to Karen and Rhonda after the meeting so that hopefully they can send it out to you all. And if you want to kind of sit with this a little bit more before providing feedback, that will definitely be possible. So our kind of objective in developing this report, which in theory would live on our website at some point, is to help Vermonters who suffer from allergies or other respiratory conditions to be able to manage their activities and symptoms using this daily pollen data. So what you're looking at here and this kind of level 1, 3 big numbers display is the average pollen counts for tree, weed/shrub, and grass pollen for, it's labeled as yesterday, but this is actually from the 28th, so Wednesday. And currently these 3 boxes are color-coded according to the National Allergy Bureau's scale, so kind of mapping the different pollen counts into either low, moderate, high, or very high categories. And the box changes colors based on what the category is for a given day. So we would be, in theory, leading with this information. So our kind of first question is this the most valuable information, these kind of 3 top-level numbers, or is there something else that might be more useful to allergy sufferers than this information? And then working down a step further, this is hourly data for the previous day for the 3 main pollen categories. And you'll see that tree pollen disappeared from here because it's currently no longer tree pollen season in Vermont. So we just have the options right now for grass or weed/shrub pollen. If it was a day in June, for example, all 3 of those choices would be here. This is mapped against what Pollen Sense calls their misery index. So that's just kind of their way. It's a scale of 0 to 100, and it's a way to try to communicate how, quote, miserable someone with allergies might be at a given time of the day. So the low category means that people with allergies, without allergies, are unlikely to experience any symptoms. Moderate means that some people with allergies may have mild symptoms. High means that people with allergies are likely to experience moderate to severe symptoms. And then very high means that anyone with allergies is going to be having a tough time. So for example, this weed pollen data, you can see how kind of throughout the day it goes up and down, and we range from the low to kind of between moderate and high by the end of the day. So a question here might be, is this misery index an intuitive way to present this data? Is it more useful than these kind of pollen count values? So that's kind of what we're thinking about here. Also thinking about, this is 24 hours of data, but whether it might be nice to also provide folks with an option to look at the last week or the last month, in addition to just the past day. And then lastly, this kind of most granular level of data allows you to look at subcategories. So if we expand the weed pollen category, we can look at all of these combined, or you can pick one specific type of weed pollen. So I happen to know, because I looked it up yesterday, that I think this is ragweed. So if someone knew that they're particularly allergic to ragweed, they could click this and see that broken out kind of more specifically. One limitation right now is that the way that we're pulling the data into the report from Pollen Sense, it comes in with the scientific names. And I need to reach out to them to find out if there's a way that we could get this with the nice, common names like ragweed or cottonwood instead of these. So yeah, I think that's all I have. Like I mentioned, I will share with Karen and Rhonda a PDF of this report so people can take an additional look at it, and kind of those questions that I pitched along the way are included in the report. So you could certainly send me or David feedback at any time, but thanks for letting us give you a sneak preview.
Well, thank you very much, Lauren and David. We really appreciate this. I open the floor to questions or comments, and reminding us of David's initial question of, does this have relevance for your work? Dr. Rappaport.
Yeah, I guess a question and comment, and I start with a comment. I think the data would be very helpful for clinicians, particularly, sometimes determining whether someone has a viral conjunctivitis versus allergic conjunctivitis. And if you could quickly go look at that pollen count. I did like the misery index, I think was a good visual. And I think being able to go back a few days or a week would be helpful in terms of, okay, when did your symptoms start? Let's look at that index and see what it was. So I thought that was pretty cool. And David, can you describe a little bit more the difference between the manual count and the automated count? Is it, I mean, it sounds like you can't do a head-to-head comparison, or, the validity or efficiency.
Sure. There have been validation studies. We wanted to purchase the instrument in the absence of those, and where they've done side-by-side manual counting and automated counting, and they find that there's good agreement between the two. The reason I feel less comfortable with doing that here is the manual counting is taking place in Williston, Vermont, outside of the home of the person who does the manual counting, while we're 30 feet above the ground on top of an office building in Waterbury. So it's not directly comparable in terms of the location. I think there's also a question of scaling too. That if you, the association might be very good, but that if you plotted one on top of another, you might need to adjust or normalize one in order to have it line up with the other. And so that's why I would have reservations about plotting them and making a claim that they were directly comparable.
Well, that brings up another issue is, the geographic location and how, relevant something in Waterbury or Williston is to someone in Bennington or Brattleboro, and how do you account for that?
Which is the driving force for us trying to do pollen monitoring in the Vermont in the first place, so that we're not reliant on national models for what, they think the pollen should be in Vermont, but not using any measurements, or reliant on measurements that are being taken in Connecticut or, Maine or Massachusetts, which otherwise would be the closest actual monitoring that's taking place. Maine purchased 5 of these instruments, and this summer started a network of hybrid monitoring stations where they're doing manual monitoring in tandem at each location, just to try to address that validity question. We didn't have the resources to be able to do it. This was sort of the best that we could do, but we'll be really interested to see what the agreement is in the work that they're doing.
Be interesting. Thanks.
Yeah.
Well, thank you both. If there are other questions related to any of the prior speakers, please add those to the chat, and we'll see if we can swing back around to address them as we go. I also just want to recognize that in our audience here, we have members from the CDC. It wouldn't be possible for us to even hold this, these quarterly sessions without their support. And we're pleased to have our program officer, especially Paige Welsh, and then also Samuel Duncan, I saw, and a few other of their colleagues are on. For those of you who don't know, the National Asthma Control Program is now housed within, I believe it's called Asthma and Air Quality Division. So these various topics are quite relevant. So we're pleased that they could join us today. So thank you both for your presentations. I've already told you about the uses I see for a B-rated movie. Misery's title is already taken, but Spores is possibly optional at any rate. Let's turn over the mic and screen to Michelle Thompson.
Good morning, everyone. Thanks for having us all here to present today, Karen and Rhonda. I'm Michelle Thompson. I'm an industrial hygienist in the Division of Environmental Health at the Health Department. I'm part of the Vermont Asthma program team. And this morning, related to climate and asthma, I'm going to be talking a little bit about mold and moisture. So let me just get my slides up here. Okay. So just moisture problems can lead to mold growth, and this topic fits in well today with the topic that we've been discussing, just thinking about the weather we've had in recent summers, lots of rain and flooding, lots of high humidity, and those types of moisture issues can cause mold problems if they're not addressed quickly or properly. So a little bit of background on mold. Mold is just a general term that's used to describe certain types of fungi. Mold can grow on different surfaces and materials like food, building materials, upholstery, clothes, other surfaces. And there are many different kinds of mold, many different types. They vary in color and appearance. And no species of mold is called black mold. That's a really common misconception. There are lots of different molds that can be black, and the color of mold does not describe what type it is or how hazardous it is. The key thing to know, and I'll mention this a few times, is that mold needs moisture to grow. So things like floods, roof leaks, plumbing leaks, excessive humidity, those can all cause mold problems. So this slide's just showing a variety of locations, colors, amounts of mold growth. The pictures show significant mold growth on drywall and wood, and just trying to show that they all look a little bit different, different colors, different sort of textures, but they're all mold growth. And again, here's some more mold photos. Again, mold on a wall. This picture on the top left in particular maybe is from flooding, because you can kind of see where the mold line is. Maybe there was a couple feet of water and that drywall was wet up to that point, and that's why there is mold growing up to that point on the wall. There's also some mold on curtains and mold on siding. And that's just to show that mold can grow on both hard and soft surfaces. And another really important thing to know is that mold is everywhere. It's indoors, it's outdoors. Even when you don't have a mold problem, it's indoors, it's outdoors. But the key thing is that it needs moisture to grow and become a problem. Exposure to mold can impact your health, and how you react to mold depends on a few different factors, including the type and amount of mold, the amount of time you're exposed, and your overall health. And exposure to mold can lead to different health impacts, including asthma, but also headaches, fatigue, eye and skin irritation, and other allergic reactions. People that have mold allergies can see more severe symptoms or conditions. And people that have weakened immune systems or breathing problems may be at greater risk of getting a lung infection when around mold. So preventing water and moisture problems in a home or a building is really the key to preventing mold growth. And here are some steps that can be taken to prevent mold growth. And we've kind of at the health department taken some input received from recent flooding events and tried to take a little bit more of a preventative approach in some of our messaging. So some of this was missing previously. So this is some new information that I think will be really helpful to people to try to prevent those moisture problems from happening when they can. Obviously, it's really hard to prevent a flood, but when you can prevent moisture problems in other areas, that's a good thing. So some steps to take include fixing leaky roofs, gutters, windows, pipes, making sure that materials are clean and dry after flooding as quickly as possible, using dehumidifiers and fans to really dry things out once electricity is safe to use. Keeping humidity levels indoors between 40 and 60%. And there's a few different ways to do that. Making sure that clothes dryers, kitchen fans, bathroom fans, those are all vented to the outdoors so that humid air isn't being recirculated back into a home or building. And using dehumidifiers in damp areas like basements. And the key to using a dehumidifier is to make sure that it's being emptied frequently so that it keeps pulling that moisture out and doesn't cause mold growth within your dehumidifier. And then keeping water away from a home or building's foundation, using downspout extensions so that the water from the gutters is being displaced a little bit further away from the building. And particularly in places where they're getting a lot of water in basements or seeing some frequent flooding issues, doing some sort of drainage system, sump pump, doing some work on the outside of a home or building to make sure that the yard slopes away from the building itself. And those are obviously larger projects, and a person would want to talk with a professional to discuss the best system, but those are things that might need to happen to prevent water from coming into a home or building. Using the right type and amount of insulation just to prevent things like condensation. And there are tools that exist to help monitor humidity levels and moisture levels in homes. So those are options. There's also things like leak sensors and automatic shutoff valves that can be used in conjunction with appliances or plumbing to help prevent water damage in a home or a building. So most often, testing for mold is not needed or recommended. And there's a couple reasons for that. Understanding test results can be difficult because there are no standards to compare the results to. So you can't use a test result to say this building is safe or unsafe. No matter how much of what kind of mold is in a home or building, the action steps are going to be the same. So it doesn't really matter what the species of mold is or how much there is. What you're going to want to do is remove the moldy items, dry the space out, and fix the water or moisture problem. So you don't need testing results to tell you what to do. And the key to addressing mold is to fix the water problem. I just really can't stress that enough. If the water and moisture problem is not fixed, mold will come back. If the moldy area is less than 10 square feet, so just say roughly 3 by 3 feet, a person may decide to clean it up themselves. But it's important to note that children, people with breathing problems, and people with weakened immune systems should not help clean up mold. And if a person does decide to clean up mold themselves, there are ways to protect themselves, including wearing protective clothing, a disposable N95 respirator, gloves and goggles. They can use portable air cleaners with HEPA filters and really try to minimize spreading dust and debris and mold to other areas of the building or home that might not be impacted by mold by containing it and using plastic sheeting to separate the moldy area from the rest of the building. And when you do see mold growth, there's sort of different categories that you can separate them into. Cleaning moldy items that don't absorb water, like glass, plastic, marble, those kinds of things. You can clean those with soap and water. Soap actually just helps physically remove the mold from the surface. You can wash and launder items like clothes or linens and throw away things like couches, mattresses, carpet, pillows, larger things that absorb water and can't be laundered easily. And then vacuuming everything with a HEPA filter after makes a big difference too. On the flip side, if mold is covering more than 10 square feet, that might be a time to hire a contractor that specializes in mold cleanup. And there's some guidance from the EPA and the Institute of Inspection, Cleaning, and Restoration certification on how to clean up mold in a safe and effective way. There are no Vermont or federal certifications or licenses for mold cleanup, but if a person does hire someone to do mold remediation and they're going to be using chemicals, that person may need to be certified by the Agency of Agriculture, Food and Markets, because a lot of the chemicals that are used to clean up mold are pesticides, and the user needs to be trained to use them properly. And depending on sort of what category you fall into, there might be different people to contact depending on where the mold is growing. So renters should work with their landlord first, and if they can't resolve the problem, they can submit a complaint to the Division of Fire Safety. Employees should work with their employers first, and if they can't resolve it, they might want to reach out to the Vermont Occupational Safety and Health Administration. And then all other concerns and questions regarding mold can come to us at the health department. I'm trying to flash through these fast because I know we're over time a little bit, but the slides will be sent out, and so if you've got questions or need to reference those materials, they will be there for you. So that's all I have. Thanks.
We really appreciate it, Michelle. Thank you very much, especially following 2 years of really significant flooding and challenges that a lot of households and people around the state have experienced. So we really appreciate it. And we were just recently at the school nurse conference, and some school nurses were facing it even in their classrooms. So thank you. I'll open the mic to just one question, just in the interest of time. Anybody? Okay. If you have any questions, though, please include them in the chat, and we can have those directed to Michelle at some future point, include them in the meeting notes. But again, thank you so much, Michelle. And I think it relates back also to the pollen monitoring instrument that also captures mold spores that are floating around in the air, among other things in terms of air quality, but also for families now. And it'll become if we see this pattern of flooding in the future, we'll be seeing a lot more families concerned about this topic as well. Thank you. So I'll turn the mic over now to Lauren Ressu, our analyst.
Thank you. Good morning, everyone. I'm going to share my screen. All right. So yes, I'm the analyst. I'm working with the asthma control program. And I'm going to bring some of these conversations back to look a little bit more directly at asthma. And a little and sort of tie that back into some of these heat-related events we've been seeing, the flooding, et cetera. So just to give you a sense of where I'm going to talk about asthma in Vermont generally. And then I'm going to talk about some of the geographic disparities we see with asthma in Vermont. And I really see this as related to the heat, to the conversation of heat, flooding, climate, because we already know that asthma is a problem in Vermont, and we just imagine that asthma could be getting worse due to some of these events. So we're going to sort of start off with where we are today. So the adult lifetime and asthma prevalent, lifetime and current asthma prevalence has not really changed significantly since 2013. We see maybe a little bit dip during the pandemic because so many people are at home, but nothing really significant has changed in the past decade or so. This means that currently about 68,000 Vermont adults currently have asthma. And then we have similar data for children. The children's prevalence also hasn't changed significantly over time. We did see a bigger drop in lifetime and current asthma amongst children related to the pandemic. Unfortunately, because some of our data sources lag, 2022 is the most recent data we have, but we see that sort of this number jump right back up after kids are back in school. And I would guess that this kind of trend is going to continue into the next couple of years at least. And this equates to about 8,800 children having asthma today. What's maybe even more concerning is that of these adults and children with asthma, about 2/3 of each category have reported that their asthma is uncontrolled. So this is really, I think, concerning for us that even amongst those that have asthma, they're having really poor symptoms. Furthermore, that adults with current asthma are more likely to rate their general health negatively than those without asthma. And if this sort of chart is new to you, we're seeing this because sort of these poor and fair categories are bigger over here than they are on the no asthma side. And then conversely, those without asthma are more likely to say that their general health is very good or excellent compared to those with asthma. So another point of concern for us when thinking about quality of life of our Vermonters with asthma. Another quality of life indicator is sleep disruption, and about a quarter of adults with asthma report having sleep disruption due to their asthma in the past month. And similarly, about a third of children report sleep disruption in the past month. And we know that not all not all groups are likely to have asthma to the same degree. And on this slide, all these orange categories are groups of people that have higher asthma prevalence than the statewide rate, including those that are unable to work, those with a low income, federal poverty level here, our LGBTQ plus Vermonters, those that smoke every day, those with less than a high school diploma, our Vermonters with a disability, those that are insured by Medicaid, those who rent homes as compared to own, and females ages 35 to 64. So given all that, we also know that the asthma differs across the state. And again, just to bring this back to heat, we know that heat vulnerability varies across Vermont as well. So this is a map that my colleagues in environmental health put together a couple of years ago, looking at heat vulnerability. So this is sort of a collation of 17 different measures, including those based on demographics, socioeconomic factors, environmental factors, health factors, and heat emergency related factors. And we can see that based on this analysis, they're really seeing that some parts of the states are more vulnerable to heat than others, including sort of this Northeast Kingdom area. There's a little sort of hot spot here in Rutland, and then sort of down here in Bennington. So this is really concerning, since these are parts of the state that have less resources anyway. And then we can compare this to what we see for asthma. So then we can sort of start thinking about how heat and asthma are related, and sort of more specifically what strategies could be used to work on both issues at the same time. So I recently, I think in the spring, I published a series of maps that look at different factors related to asthma across our state. And I'm going to put the link into the chat after I'm done here. But I just pulled out all these maps to talk through here in this presentation. So the first series of maps have to do with risk factors. So things that we know based on literature, based on other public health studies, that these are factors that are tied to worse, that are sometimes tied to worse asthma outcomes. So this particular slide includes two maps based on housing, the percentage of housing units built before 1980, and the percent of housing units that are rented as opposed to owned or vacant. So we can see here that, and one thing that's really interesting, I think, about this analysis is that we're not seeing kind of these darker, sort of worse areas in the same places for each factor. So our sort of southwestern part of the state, Bennington and Rutland have older housing, as well as Washington County. But then if we look at the percentage of housing units rented, we see that Chittenden County has a higher percentage of this. And I think this is really helpful for us to think about, because we very rarely see with our data that Chittenden County stands out as having worse outcomes in many ways. And so I think this is really important to to sort of bring us back to, it's really vital for us to look at these really specific factors when thinking about how to best support our Vermonters with asthma, or whatever group we're looking at. For further risk factors, percentage of adults who smoke is higher in the sort of our northwestern part of the state. Average PM 2.5 concentration. Rutland really sort of pops up here. And then our percentage of adults not vaccinated for flu, we see Essex County as being the darker color here. So again, these risk factors are distributed sort of all throughout the state. Similarly, if we look at not exactly risk factors, but populations that have worse asthma outcomes in one way or another, we can sort of see, just looking at this slide altogether, that again, these are really distributed throughout the state. So median household income, those with lower incomes we know are more likely to have asthma. And then of those with asthma, those with lower incomes are more likely to have uncontrolled asthma than those with a higher income. So we really see the Northeast Kingdom there and Rutland popping up. The percentage of population is Black or African American alone, and this is included here because we know in Vermont, this population is more likely to visit the ED for asthma than other groups. So that group, we have higher percentage of those individuals in Chittenden County. And then the percentage of populations that identifies as LGBTQ+, we see higher in Chittenden, Addison, and then down in Windham County. Then if we turn our attention to prevalence, so the actual outcomes, instead of sort of risk factors or demographics, we sort of see that the southern part has higher asthma prevalence. For adults, it's really in Windham County for whatever reason, and the child prevalence we see higher in Bennington and Rutland counties. And then lastly, this slide is looking at a variety of sort of quality of life or sort of severe outcome factors. And so the percentage of people with asthma had an asthma attack in the past year. We see Essex popping up here, but kind of darker red throughout the state. Rate of ED visits with a primary diagnosis of asthma, again, higher in these two northeastern counties. The percent with uncontrolled asthma and percent with fair or poor general health. And then because just looking at these visually, these seem to pattern a little bit more closely than either the risk factors or the prevalence maps. So I sort of did a composite map here, combining all 4 of these maps into one and kind of taking the average score in each county. And here we really see that Essex County is popping up. You can see that visually, right, just from the 4 maps too. But this county is much has generally worse outcomes than other parts of the state. But we also see that I think this is interesting. Rutland is popping up, which I think is not surprising given that they have a number of risk factors. They're higher for a number of risk factors. Windham County, which I'm not sure we think about that much, and Addison, I think, was surprising to me. I don't think we think of Addison as often having worse outcomes. Grand Isle, a little bit, Caledonia, and Orange Counties here too. So just in general, I put these out of order, but we can see that asthma and asthma-related outcomes related to asthma are really a significant concern in Vermont, and we would only expect them to get worse with more heat events, more flooding. And second, the geography of asthma in Vermont is pretty complex and suggests that first, the entire state needs support. There's not one part of the state that is really really doing well and throughout all of these outcomes. But then the support that each part of the state needs really is different. So we really should sort of think about what we're doing and why we're doing it in each part of the state. I'm gonna go back and just, these are some resources I usually hand out. So this is our link to the asthma program. This is where most of our, all of our asthma data sits. And then this is a link to the maps that I showed here specifically. And as I said, I'll put that into the chat. So yeah, that's it from me. And please, I'm happy to take any questions if there are any.
Well, thank you so much, Lauren. We really appreciate this, bringing it back around to specifically Vermont's asthma population. I just wanted to ask, in light of what we're seeing in Vermont, could you just speak briefly about it in light of a national lens, given where we also stand nationally as it relates to asthma? Can we kind of consider these as compound, pockets on a national scale too? We often speak of Vermont as, top 5 in the nation. So if we start looking at these subpopulations, can we kind of generalize to that too, in terms of those regional subpopulations?
So yeah, we are usually in the top 5 for adult asthma prevalence. So we we definitely have some worse outcomes compared to other parts of the nation. And I'm not sure. I wouldn't want to generalize anything I said here about pockets because I don't know. And I think that's a really big question. But I mean, I'm sure that outcomes are not the same everywhere, right? And risk factors are not the same everywhere. And so I'm sure that's likely the case, but I wouldn't want to say that exactly.
Well, thank you. I know I know we really appreciate the work you've done, especially these last disparities map, as we tried to explore and delve in deeper to social determinants of health and drivers of those disparities. So these have helped us look at like rental properties, old housing stock, and other topics with much more close-up lens. So thank you very much. I also want to just stop for a moment and thank you so much for all of your contributions to the Vermont Asthma Program. Lauren is moving up in the world and within health surveillance and taking on a new role, though she'll help us transition. And so we will begin work trying to find someone to fill the role of analyst for the asthma program, but we will greatly miss her contributions, as we've just seen here now, and wish you the greatest success in your new role, but we won't be letting go of you completely for quite a while. So thank you again for all of your contributions. They've been invaluable to us. Thank you.
Thank you. I've loved working with this program, and I've loved attending these meetings, and I've learned a lot from this group. So it's a great resource to the community. Thank you.
Thank you. So now I'll move on and turn the mic and screen over to our external evaluator, Emily Grubner.
Thank you, Karen. I'm going to put a link in the chat, and I invite you all to join us on Menti. If you've been to an AAP meeting before, you might remember doing a Menti. But we're going to kind of like flip it. So we've heard a lot of presentations, and now we kind of want to hear from you and what you're seeing in light of what we've been hearing. So you can either click that link in the chat, or you can follow the directions on the screen. And we'll just kind of dive into like reflecting on what we've heard today. Give you all a minute to join. Right. So I think the instructions will stay on the screen, but given our timeline, we're just going to take about 7 minutes to kind of do some questions. So the first one is thinking about what we've heard today. There's a lot of impacts on Vermonters relating to climate. So to what extent are you seeing the impacts of climate change on Vermonters with asthma in your work? So this could be from a state health department level. What are you seeing? What are you seeing in your clinic? Just trying to get a sense of how impactful this is on Vermonters with asthma from your perspectives. Great, starting to see some answers roll in. Seems like a lot of people are saying somewhat. So kind of in the middle there. Right, so keep putting those answers in. It's really helpful to just see where we're at. I'm going to go on to the next slide. And so reflecting again on what was presented, how are you seeing this impact? So a lot of you said that it's somewhat, to a great extent. What does that look like in your day-to-day? What are you seeing? Just help us get a sense of what Vermonters with asthma are experiencing from your perspective. And you're welcome to use Menti. You can use the chat. You're welcome to come off mute and just talk about it. This is a space to kind of work with our colleagues about what we're seeing. Right, seeing some responses start to come in. School nurses having a hard time getting asthma action plans. Concerns for high levels of uncontrolled asthma, wondering if it's climate related. Increased risk for asthma exacerbations on hotter and more humid days. Having adult onset asthma and feeling the impact this summer. I'm remembering at the beginning of this call, there were some individuals from schools that were kind of wondering how climate is affecting that school health piece. I'm wondering if you wanted to expand on that at all. Are you thinking about flooding or like those hot days? What's coming to mind when you're thinking about climate in schools? Or maybe we heard a lot about pollen tracking. How is that showing up in your work? I'm curious, does anyone want to come off mute and kind of talk about what they're seeing? You might have entered in a Menti response, or you might not have, but welcome anyone to come off mute and talk about it.
Hi, my name is Jess LeClaire, and I'm a school liaison who works with schools in Chittenden County. And I don't have a lot of, like data about how asthma is being impacted by the heat, but I do have a lot of nurses reporting that it's so hot inside the schools that they're having issues for both staff and students. I've had nurses talking about having 90-degree inside the school, inside the nurses' health office. And I do have a school in our area that's dealing with mold right now. So that's been an issue. And what someone said about OSHA, well, I get so many calls all the time asking because there are rules around how cold it can be in a school, but there doesn't seem to be anything right now about how hot it can be.
Thank you so much for sharing. Does anyone else have similar experiences, similar questions? I'm seeing some in the Menti about concerns from workplaces and employers. Schools definitely fit into that. Well, in the interest of time, please keep putting your responses into Menti. I want to make sure that we give the next speaker full allotted time. So I'm going to move to the next question, just asking if there's any specific resources that you use that you would want to share with a broader audience. Like I use this in my work, it's really great, and others should know about it. Feel free to put that into Menti. And then at the last page, you should also be able to click on, there's just a few resources that came to mind that might be helpful. You may have seen them before, you may not have, but I know there are a lot of resources shared throughout this meeting as well. So thank you all for your engagement. I'm going to stop screen sharing, but the Menti will stay open, and I'll pass the mic.
Thank you, Emily, and thank you, Jessica, for your comments about the schools and school nurses challenge. And yes, and appreciate any of your continued statements in follow up to the questions Emily mentioned in the chat. We do plan to use any of those resources and or any challenges you're beginning to see as it relates to climate change or recent events in terms of what might be related to climate change. And so at this point, though, I'm very pleased to turn over the mic and screen to Dr. David Kaminsky.
Thank you, Karen. Can everyone hear me okay? Okay,
Yeah.
Wonderful. Just full disclosure, I'm sitting in a little conference room outside the intensive care unit. I have someone to cover me for the next 20 minutes, but I can never predict what may happen, but I should be clear to speak with you for the next 20 minutes or so. And let me share my screen here. Sorry, I'm just having trouble finding it. Rhonda, I sent it to you. Is there a way you can pull it up?
I can try to. Rhonda, do you want to try it?
I see it now. Yep,
it just came up.
Yeah, looks
it
great.
Just came up. Okay, very good. And I'm just going to put it on there. Can you still see it?
Perfect.
Okay, great. Well, again, thank you so much for inviting me to speak. The title I was given was Clinical Evolutions and Challenges, and I'm a little afraid that maybe what I'm going to talk about has already been discussed to some extent. So I apologize for any redundancy, but the way I saw this was as a physician, how do I see what's going on with climate change and asthma, and what can we do about it? We're not going to be able to solve climate change, obviously, right away, but what can we do more in the short term? And I hope to just share a few examples and perspectives with you. So are you just seeing the next slide? I just want to make sure they're advancing okay. Is everyone seeing that?
Yes, it's great.
Okay,
Looks
great.
good.
So this is a nice diagram I found that just kind of summarizes what we think are the effects on asthma of climate change. They have to do on the left-hand side with increased ambient temperatures relating to heat exposure, outdoor allergen exposure, formation of ozone, and then we've got problems with particle matter due to forest fires, and then we've got flooding and mold and so forth. And so you've talked about a lot of those, it sounds like, so far, and I'm just going to highlight a couple of these key areas. Air pollution. You know, we all saw that famous picture from New York City last summer with the terrible wildfire smoke that came down to New York City. But around the same time, even in Vermont, we were seeing the haze, as you can see on the right. And there were some interesting data from the MMWR in August of last year that showed how there was a clear-cut trend in emergency department visits during the wildfire smoke. As highlighted in the blue, you can see that when smoke exposure occurred, there was a big bump in daily visit volume of emergency room visits that corresponded exactly when the particulate matter got very high in the air. And this was seen in New York City also. On the left-hand side, the exact same thing. The smoke wave occurred during that yellow bar in the middle, yellow-orange bar. And in reference to the periods before and after, which are shown in blue, you don't need numbers to see the huge spike in emergency department visits that occurred throughout all the boroughs of New York City. And on the right-hand side is just an example in all age groups how the smoke wave resulted in many more emergency department visits. So one of the things we can do right away, of course, is just to monitor for this and warn patients and warn ourselves when the air quality is going to be bad. And this is just a screenshot of my own phone when the day had a bad forecast back on August the 16th, where we were in the moderate levels of particulate matter. And so this obviously is one thing that we can do to protect ourselves and our patients, to teach them how to use this type of app. This one's Air Now, which is run by EPA, so that they know when not they can go outdoors more safely, or whether or not to engage in vigorous activities and so forth. Moving to pollen, we've seen a lot of pollen year after year in Vermont, especially when those pine trees release their pollen. I know it gets all over my car and outdoor furniture. And there have been studies of this. This is a recent study here showing the effect of pollen burden on asthma. On the left-hand side, you can see that as the annual temperature rises to the right, the pollen counts from all different parts of the US and Canada also rise, as shown by that dark line. And in the middle, the day of season start is getting shorter and shorter with temperature rise. In other words, the pollen counts are getting higher sooner in the year. And likewise, on the right-hand side, the length of the pollen season is getting longer too. All direct effects to temperature, which we think are related to climate change. And this was just a map showing the trend over time in the pollen burden. And you can see that anything that's shown in pink or red is a positive trend, meaning more and more burden of pollen occurring in different sites around the country and Canada, with the size of the circle representing over what period of years this has occurred. And while there are a couple blue circles there, most of them are in the pink and red zone. So just like smoke, we can monitor for pollen, and it sounds like you've already talked about this, but I think this is critical, again, to teach our patients how to use these apps. Luckily, there are monitoring stations all over the country, and they can give us some sense of what the local pollen burden will be on that particular day. And so people can inform themselves about whether or not it'll be a great day to go out for that big hike, or they want to postpone it for another day, or for children to be careful outdoors, etc. And interestingly, unfortunately, air pollution and pollen are synergistic. These are data from another study on the top showing the daily ED visits in New York City associated with wildfire days that are highlighted by the tall spike that's labeled wildfire days. And you can see that down below is the pollen counts, and they corresponded to the wildfire days. Now, you could say that the wildfire days were accounting for everything, but the pollen counts themselves were also associated with increased ED visits, as you see in the spike to the left, where it's labeled wildfire days. And so one study has looked carefully to say, well, could there be a synergy between extreme weather and air pollution and pollen counts? And here are some data from a study published back in 2012, where they looked at the estimate in among 11 cities of whether or not they would be more likely for someone to visit the emergency room for asthma. And you can see, for example, here, the relative risks are all above 1, meaning there's increased risk of an emergency room visit due to asthma due to exposure to these various pollutants, carbon monoxide, PM10, oxides of nitrogen, and so forth. But that, compared to days when there were higher pollen counts, you can see the relative risk actually went up. And so the pollen counts and the air pollution are acting together to increase these risks for emergency room visits. And then extreme weather is something that's talked about a lot these days, and we hear about it all over the globe. On the left-hand side up above, you see extreme weather events that are labeled blizzard, ice storm, cold spells, and so forth. And what you're looking at is odds ratios of people presenting with asthma symptoms on the top or emergency room visits on the bottom. And most of these symbols are to the right of the number 1, meaning there's increased risk. And I just want to highlight one of these, which is quite interesting, which is thunderstorm asthma. This has been described around the world, but most dramatically in Australia, where there was a big outbreak in 2021 in the city of Melbourne. And what they were able to show, if you look at the right-hand graph there, the thunderstorm asthma events in blue went up dramatically during the storm compared to typical presentations to the emergency room over time shown in the gray. And it's thought that what happens is during a thunderstorm, there's extreme wind events that occur that raise a lot of pollen and dust, but also the moisture associated with the storm and then the change in barometric pressure actually causes many of these pollen fragments to burst apart and release multiple numbers of particles that get in the air and can cause an acute exposure, which patients with asthma are especially sensitive to. And on the right-hand side is an air sample that was taken during this time. And you can see intact pollen grains, as well as those that have been ruptured, as shown by the double arrow. Those are pollen grains that were ruptured and released all of their particles. So I was interested to see that the state of Victoria in Australia, which is where Melbourne is located, had a very official Inspector General report about this, where they reviewed the event and they made all sorts of recommendations, among which were public notices like the one you see on the right, letting people realize about the potential danger of thunderstorms and people with asthma. If you wheeze and sneeze in the spring, especially be careful. And then finally, I wanted to mention flooding. This is a picture of Linden, July this year, during one of the many flooding events that we had. Here, as you talked about, I'm sure, flooding events are associated with increased burden of bacteria and fungus, both locally and also in the air. As you can see by these studies here that actually tried to culture these organisms. In the red are the numbers in the flooded areas versus in the blue, the not flooded areas. And you can see statistically significant increases in the burden of organisms. And so the American Thoracic Society, among other organizations, has put out some general information. I don't expect you to see this to read it, but just to see, this is a 2-page summary for the lay public about what to do if you have flooding and you're concerned about mold and how to mitigate against mold. So like the other examples I've given, these are ways in which hopefully we can educate the public to deal with these changes that we're going to see due to climate change. And the CDC also has an extensive publication online for homeowners and renters on how to deal with mold and clean up after flooding events. So in conclusion, what I hoped I've demonstrated is that, first of all, as you've already talked about during this morning conference, there are many effects of climate change on asthma, and I've highlighted just 4 areas: air pollution, pollen and allergens, flooding, and extreme weather. And I think the keys to mitigating these effects on asthma are, first of all, education, early detection and monitoring. Luckily, in this day and age of smartphones, we have a number of apps available that can provide this to people real time. And then, of course, informing people on procedures to reduce risk, wearing masks, avoiding exposure, how to clean up after a flooding event, and so forth. Sadly, we want to tackle climate change at its root causes, and this is a diagram that I just found randomly that shows you how complicated that's going to be. So without going into any of these details, realizing that we have to deal with multiple different factors involved in climate change, which is going to take years and decades to solve. But until then, hopefully we can use these measures I just mentioned on an individual scale and on a small population scale to help people with asthma not be so affected by these changes in climate that can affect their breathing. So with that, I'll stop, and I'm happy to take any questions.
Thank you so much, Dr. Kaminsky. Anybody have, yes, Rhonda.
No, that was excellent. Thank you so much, Dr. Kaminsky. Are you advising your asthma patients to wear masks during, these climate-related events? And I just wanted to see if your guidance is including that.
In general terms, now that especially since last summer when we had all the smoke exposure, I am telling patients to either avoid going outside altogether if they can on those particular days, but then yes, to wear a mask. And in fact, I give an example of my own experience. My wife and I were taking our dogs out to walk one of those days, and we noticed it, and we don't have asthma. And we actually put our N95s on, which we had around the house because of COVID. And honestly, the walk was much more enjoyable. We didn't have the scratchy throat and the runny nose because we were covering our nose and mouth. But yes, telling people to avoid exposure those days. And then I do recommend that people ideally have an air filter in their bedroom, a HEPA filter, because these exposures outdoors do come indoors. And, in the summer, we all want fresh air, but when we bring fresh air in, we're also bringing in pollen and allergens and pollutants. So ideally, running an, windows closed air conditioning unit, but a lot of people don't have that. So at least trying to run a HEPA filter can help with the local air quality in the bedroom.
Any other questions? I can't see everybody's hands if there's a hand up. Dr. Kaminsky, I saw a national news that a pulmonologist was stating that the air quality really bad at those, like the New York days you showed a picture of, could actually be a cause of new cases of asthma. Do you think that we will be seeing prevalence rates actually go up over, we're talking longer term frame, but over the next decade?
Boy, that's a really good question, Karen. I don't know the answer to that. There is precedent for that happening, but not so much with air pollution, but rather with one-time intense industrial exposures can result in what used to be called reactive airway dysfunction syndrome, or RADS. RADS is a one-time exposure that results in persistent asthma. We also know in adults in particular, but certainly in kids too, but in adults, a lot of adults think, how can I get asthma at age 70 and 80? I never had asthma before. But we see that not infrequently, and it's usually in the setting of a one-time bad flu or one-time bad upper respiratory tract infection. So I think current thinking is that literally there's an injury that takes place to the airways upon exposure to some of these viruses, for example, or these industrial exposures. And for unclear reasons, the airway can't heal in a normal fashion. And so it ends up healing in the way in which it becomes hypersensitive to further triggers in the future. And that's basically what asthma is. So I do wonder if probably not general air pollution or general pollen exposure, but maybe very intense one-time exposures could result in this. I don't think anyone's looked at that in the thunderstorm asthma events that occurred in Australia, but that would be sort of a natural experiment to see if someone who did not have asthma then had it afterwards. But it would be awfully hard to kind of track that. I think more it's going to be a persistent indolent kind of problem. In other words, people with asthma having repeated exacerbations and their asthma might get worse rather than it causing new asthma. But I may be wrong about that.
Interesting. Well, we thank you. It's as if you were perceiving all the presentations because you wrapped it up really nicely and bringing a full circle on so many of the topics that had been discussed previously. So thank you very much. It gives us a lot to think about. In the last few minutes, I do want to just mention just a few highlights. Today is the last working day of our 5-year grant cycle. And so we will bring that to a close over the next couple of months. And then on the 1st of September, we start a new cycle of 4-year cycle of grants of this grant with the CDC. Again, thanks to our colleagues, CDC collaboration team for all the support along the way. And as we transition to this new grant period, more will come on that focus as we go along. And we will begin to recruit for a program manager for asthma very soon. I will begin to work on a new COPD program with CDC funding, and will kind of keep my hands in a little bit of asthma and support the new program manager. But we're excited to be growing our respiratory health focus, both in asthma and COPD. And I think you saw the great product that Michelle led the creation for. It's the Safe Cleaning in Schools document, which was based on data we had from Informed Green Solutions of audits of what products were found in schools. We believe some increases in dangerous cleaning products were introduced post-COVID or through COVID. And so we're hoping that we can begin to work on that and see reductions in those more dangerous cleaning supplies. Any last comment from you, Rhonda? Let's close it. No? All right. Well, thank you to all the presenters. Thank you, Emily, for your engagement element. We look forward to seeing some of the results of that and summaries of what were contributed. Thanks to all those who put resources in the chat. And we look forward to seeing you in the new grant cycle. And thanks so much. Have a great long weekend, labor-free, I hope, weekend.
Thank you, Karen. Thank you, everybody, for joining.
Thank you.
Thanks, Dr. Kaminsky.